Welcome to another inspiring episode of the Global PAD Impact Awards, where we celebrate the remarkable achievements of individuals and organizations dedicated to transforming the field of peripheral artery disease. Now, today we are honored to present the Peripheral Artery Disease Physician Humanitarian of the Year 2024 Award. This prestigious accolade is reserved for a physician who exemplifies unparalleled, as I said it, unparalleled compassion, innovation, and equity in the care of PAD patients. This physician's relentless dedication ensures that each patient receives personalized and exceptional care, making them feel valued and understood, as if they're just the most important person in the world. The Global PAD Impact Awards recognizes those who have made exceptional contributions through research, innovation, patient education, advocacy, and leadership, and our awardees are celebrated for their selfless commitment to life and limb-saving care, significantly enhancing the quality of life for PAD patients worldwide. And without further ado, it is my great pleasure to announce this year's recipient of the Global Humanitarian of the Year Award, Dr. Kumar Madaseri, interventional radiologist at Rush Hospital in Chicago, Illinois. Please join me in welcoming Dr. Madaseri to the show. Congratulations, Doctor. We appreciate you so much.
Thank you so much. Yeah, it was very humbling, and honestly, it was a surprise to get your email with the announcement, and I can't be humbled enough and say it's a tough fight for all of us, but we all hopefully can do better and better together. So I sincerely thank all of you. You guys are the reasons why we do what we do.
Well, it's amazing because when you first presented at our conference, I think it was 3 years ago, you handed out your cell phone number to multiple patients and said, because you heard their stories, you felt they were not being heard. You felt like they weren't getting the care that they felt like they deserved. And the feedback that I've gotten over the years of the number of times that out of the goodness of your heart, even if they didn't end up being in the area where they could go to you, or even if they were, you were always there for them. You still are there for them. You were always responding to their questions, to their concerns, and even expediting. We had one patient that you were able to, even I think you were out of the country, that this patient was not getting the care they needed in another community hospital, and you even were able to help from out of the country create this transfer to Rush Hospital so that they could get the care they needed. So you are always one to go above and beyond to do what is right for patients. And it really means the world to each and every one of our patients, but also to me and our entire network. So again, thank you so much.
Of course, I mean, I think that's what we signed up for. This, in the journey of what we do. Sometimes it gets forgotten, but literally, it's literally all we can do for what we signed up for.
Yep. Well, I think it's more than that. You definitely have to have a heart. There's some that just, do the 9 to 5, and there are others that literally recognize that this is, a life commitment. And it's amazing that you live that every single day. So I'm curious, I would love for you to share a moving patient story that exemplifies your commitment to providing compassionate and personalized care for those living with PAD.
I mean, to start off, I'll say the patients living with PAD, it's very heartbreaking because there's so much we should be doing decades before they found out they had BAD to get them to never be in that situation. And a lot of it's things that if there was better education on how to take care of health and how to do simple things in life that I think our ancestors used to do naturally, it would get them to there. So when I'm seeing these patients with PAD, almost every single one of them's a little emotional story because they just say like, I just never knew had I known. And so this the stories are so many, but I'll say one of the stories I can think of is I work in the wound care clinic also, so I actively do wound care. Patients who come in with venous ulcers, arterial ulcers, lymphedema, we take them in, we do debridement, skin grafts, whatever. And there is one particular patient. She's in her 90s and really just really really wonderful, but small, shorter, frail woman. And she comes with a wound, and one of our nurses in clinic had specifically put her into my clinic and said, "Hey, please see her." And so I talked to her, and she has a wound on the top of her foot, and she lives in a senior citizen home, but she's very active. She's an avid gambler with bridge. She has her crew. She does all the work, and she just has a miserable time right now because she has pain from this wound on the top of her foot. So I'm talking to her, and I said, "What's been going on?" And she goes, "Well, it all started a few years ago when I had a procedure for one of my arteries in my pelvis called the iliac artery. She was getting a stent done, and had the stent done, but unfortunately there was some kind of complication during the endovascular procedure and ended up having occlusion of her arteries on that side, emergency surgery. She had to have what's called fasciotomies of her leg, which is where they have to cut the skin open to allow the leg to survive because so much pressure is built up from this acute event. So she has all these scars on her leg and this complications in her groin. She had to have her artery in her groin called the common femoral artery repaired. So she went through all this. And then when she is walking around her home, she has a wound on the top of her foot, and now she has rest pain, which is pain that keeps her up at night every night. Anytime her leg is up, because her arteries just can't keep up with gravity because of the PAD that she has. She has so many different areas of problems, and so she can't sleep. All she wants to do at 90 years old is play bridge and enjoy, her whatever time she's got enjoying her life. And now she can't sleep. She doesn't do well with narcotics for pain, and that's not a way to live. And she has a wound that is not healing. So she said that the other institution said they can't touch her because of her age, because of what she's been through, because of her scarred and groin. It's not safe with what all she's got going on, and it breaks your heart because she's like, I just want to walk and enjoy these years. So, we had a lengthy conversation. Her family's in the medical business, had to talk to them, had to talk to her prior surgeons at the other places, and they were all saying this is a very risky idea. And I had a frank conversation with her, but she was just crying, saying, I don't care, whatever it takes, do something. So, you know, took that chance, did a procedure, was able to get her blood flow restored, and it took about 3 months, but we healed her wound, and her rest pain was better. But that's not the end of the story. As most of you know, with PAD, it's often not a one and done. We
Right.
got her healed. Her wound was gone. She's walking, and then her other leg, she fell because she was walking better. Got a wound on her other leg. So then, we had to have that difficult decision. What do we do now? Do we do another procedure? But instead, we opted to just work with her, talk to her. She has physical therapy, said, let's do aggressive wound care. Let's try to manage this. It's a risk every time to put her under anesthesia because she needs anesthesia. And we were able to heal that too. So that was great. And then about 2 months later, she opened up the other wound again on her foot because she decided to get some new shoes. So, it breaks your heart because she just wants to live outside of the hospital and the clinics, but because of everything that's happened to her, because of what she's going through that. So this has been now, as of I think about 2 weeks ago, we finally healed her right foot again, and it involved about 3 months ago doing another intervention, which we tried to avoid, but she was so miserable with her pain. So it's not a life is great from now on, you never touch her again, but it's like, can we still take a chance with somebody if they're willing to take that chance? If they want to take that journey where they feel there's more meaning to their life than just saying, you're too risky, you're too sick, you're too this or that. Some patients are, and some patients you don't want to push the limits, but taking care of her and seeing her, and I can see her face when you walk into clinic, whether she's doing well or not, because she either has a smile on her face or she looks down. So I had to get her a therapist, get her into an emotional support because she was feeling very down. And if
Oh,
she's feeling depressed, she's not going to do well.
oh.
So, this is not uncommon story, but it sticks out in my mind because nobody wanted to help her.
It's
And,
so
she's still,
interesting. I mean, because I was just going to ask, how do you ensure that your treatment plans address not only the physical challenges, but also the emotional struggles that PAD patients face? And you just answered that. And there's so many doctors that don't understand that there's a real emotional component when it comes to PAD, and especially when you're telling patients that there's nothing that you can do for their pain, or go ahead and you need to walk through that pain, and there's an emotional struggle that goes along with that to kind of get up that mental strength to be able to put up with that pain while you're walking. And even You don't want to look forward to walking in that kind of pain to grow those collateral vessels. So it's amazing to see that you're taking this holistic approach, and really it goes to show why you deserve the Humanitarian of the Year award. It's because you're taking an active approach to creating that holistic care for these patients.
Well, I mean, I think, I think we've talked about this before. When I talk about this stuff, I use the term arterial cancer, and some of you have heard me say that there's no such thing. But I use that because it delivers a high blow to someone to understand this is like a cancer. This PAD, and when it turns into what we call critical limb ischemia, CLTI, it has a mortality rate, if untreated, unmanaged, that's higher than most cancers. Everybody in the world is so akin to the emotion and the shock of the word cancer but we don't put that kind of emphasis on this. And cancer patient gets incredible amounts of support out there in terms of emotional, physical, public awareness, walks, marathons, fundraising. But yet this disease process that kills more people than that within 5 years, it's still not well managed, understood, supported. So I think I use that term to tell patients how serious it is, but how much we have to do from a global sense of their care. It's not just it's the nutrition, it's the mental health, it's the life pain control. Who's their family support? Do they have support? Can they get some support? There's so much that goes involved in PAD, and especially when they get to CLTI.
What really drives your passion for treating these patients, and especially those that are in the most vulnerable communities that are typically the toughest to get into compliance with doctor's orders?
Um, that's a very tough question. What motivates is the fact that you can sometimes do something that others won't or can't. And that's not saying it's some incredible technical necessary. It's more like the willingness to take the time, the cost of the procedures, which can't be taken on everywhere, the support of a hospital system that can handle a lot. Those kind of things motivates me when someone says can't be done. The question is why. And there are times when the answer is nothing, something can't be done or shouldn't be done. And we have to be good about that. But a lot of times, I'd say half my patients that come for second or third opinions for wounds, something could be done or could have been done. Um, Handling the inequities in the system. I work in the city. I work on the west side. A lot of my patient population here are those who are the most affected by quality of care. Even though we're at many medical centers here, many of them never make it to the center for early preventative care. It's different than if you live in the north suburbs, the western suburbs, the suburban areas of many parts of the country, where that's not your typical patient population coming in with gangrene or rest pain. So I think it's honest that when you're surrounded by people that aren't being served properly, is how can we do better? And unfortunately, many of my patients are in the wound state. Those are my terminal stage patients that we need to try to get back into remission, into the PAD, claudicant, or managed stage. So I think the motivation is why can't we do better?
Yeah, I mean, it sounds like I'd love for you to share another story of how you have championed health equity, ensuring that a patient, regardless of their background, that you've helped them feel valued and receive the care that they deserve.
I think the reality is a lot of patients who've been through in that scenario just haven't been listened to. A lot of times they're treated with their numbers, their imaging, whatever possibilities are as a procedural standpoint or a surgical, whatever it is, rather than what's actually going on. Because when you tease out a lot of the patients that have PAD, their problems may not be just their PAD. It could be their nerves in their back. It could be their sciatica, their neuropathy from everything else. A lot of times they're just not heard. They're just seen as like a checkbox. Do you have something I can treat? Yes or no? No. Okay, we're done. And just deal with it. So it just takes a little bit of listening to kind of getting other people in your whatever your multidisciplinary approach is, and asking your colleagues as physicians, hey, take a look at this for me. Do you think it's something else? I use my physical medicine rehab specialist, PM&R, a lot because they do musculoskeletal and nervous evaluation. They do nerve testing, nerve injections, they do muscle balance, all that stuff. It's like sometimes you can get patients doing better by just not doing a procedure, but getting them the right kind of overall physical care. So I think it's who else can help you. And if they say there's nothing to do, that's fine. At least you're checking off boxes. Some patients can't be vascular treated, they're not appropriate for it. There's pain control. Spinal cord stimulators have been shown to show some significant benefits in PAD, especially in limb problems. So it's something to consider. So I send them to the pain specialist, say, hey, what do you think about a test with that if they're willing to try it? Most patients just want to not be in pain. They're not as concerned about the number in that scenario. They're not like, how good is my blood flow, this and that. They are important, but their question is, how can I get out of this pain so I can live my life? How can I live with my spouse, my family, my kids, my grandkids, my job? It's how can I live my quality of life? So we need to work on quality of life metrics more than just numbers on an ultrasound or pictures on an angiogram.
It's so hard because for each individual, it is unique to them what a better quality of life means. And so, I'm curious, so much is in the hands of the patients when it comes to peripheral artery disease, especially in the intermittent claudication stage and even lifestyle limiting stage. How do you empower your patients through education about lifestyle modifications and what they can do to live a better quality of life by improving their symptoms on their own?
Yeah,
I
you
know I
got
have a story of a patient that you and I both know exactly who it is just recently. And she was expecting to go in there and she was going to be told that she was going to have a procedure. And I really thought if she walked out of there without having a date for procedure, I thought she was going to call me up and have a complete tantrum. And instead, whatever you said to her, I ended up with my text exploding with every single GIF and animation and explosive dancing girls and whatever else. And she was motivated to do everything and anything in her power to improve her symptoms. So
yeah.
I want to hear
I know
that
who you're talking.
motivational speech.
I don't think it was a motivational speech more. I think it was that, it's trying to understand what's limiting them from doing better for themselves. A lot of the risk factors that we deal with for PAD in a patient that is not in the critical stages is the same lifestyle risk modification that we tell any patient for anything. Please don't smoke. Please try to eat healthy. Please try to walk more. I think ever since we became a technologically savvy society and COVID and all these things, a lot of people, including our younger generations, are very sedentary, even more than ever. It takes 2 minutes to order any kind of food you want delivered to you, even though it's down the street.
Yeah.
And it's what can we do to get you to do things that for any part of your body that you need better, but especially PAD, most of them have never been told the reality of what's going to happen to them if they continue the way they are. I tell them if this continues the way it is, you're already 20, 30 years behind. You're going to potentially lose your leg and you're potentially going to lose your life because the same problems that's causing their intermittent claudication is going to cause them to have a stroke. It's going to
Yep.
cause them to have a heart attack. Everybody understands a heart attack, and I tell them, you don't get a heart attack from one day of plaque in your heart arteries. You get it from years, and at some point, your muscles starve so much in your heart they get a heart attack. Your legs are now getting leg attacks.
Yep.
So it's the same thing. So what can we do for you to understand that if you don't do your job while we do our job to help you, we're going to end up in a scenario where you're going to be really in a detrimental state, and we can try to prevent you from getting there. So it's unfortunate it's like coming to like a Jesus talk or coming to a real talk about, has anybody told you where this is going to go if this doesn't get better? And
Hmm.
also we ask them, bring their family in there if you can. What's the limitations for you in your life? Is it your where you live? Is it your job? Is it your support structure? Is it financial? What is it that limits you from being able to eat better, walk more, get outside? Maybe you do a great job with this, Kim. Get a pet. Get a dog or animal and walk. It's kind of addressing those things. And that patient you're talking about, she had a bypass, and I don't know. She doesn't really know why exactly she had a bypass.
No,
Um,
I actually
but
find that a lot.
but when she comes to clinic to do something about it, but she's walking into clinic as an outpatient and she's walking from our garage, which is kind of a big place, to my clinic, you're already doing better than most patients. And I'm not sure why your bypass was done and why you're struggling. Are you struggling with the bypass being down? And she was not struggling. She was just told to bypass down, something needs to be done. But she's walking, she's living her life. She has some other risk factors she has to adjust. And once we talked about that, She totally understood that, said, I will do whatever I can to avoid needing a surgery, but if I need a procedure, I understand I can have it done. So it's kind of that setting the expectations the right way, because I guarantee you she would have been on the table with somebody, and that I'm not against it if that discussion is what everybody wants to do, but I can tell her your bypass already went down. Anything else we do or another, it's going to go down at some point. Do we really want to start that cycle again right now?
Right.
So
And
it's
this is what the way, and you've been one of my greatest mentors. And say what you've been saying all along. It's not a matter of if these procedures are going to go down at some point. It's a matter of when. The goal of these procedures is to give you just that much more blood flow to either heal the wound or give you other symptom relief so that you can get out and walk, walk, walk to build those collateral vessels so that when they do go down, you're not going to need another procedure. You have enough collateral vessels bringing enough flow to your feet so that you can still live the quality of life you desire.
Yeah, you've seen, how many patients have you seen? You monitor their walking, you do programs with them. The fact that they walk more and more, and we've had several patients together on their own without a procedure, tells you that it does work. But if you're struggling and you can't function or you have a wound, we have to do something to get you to be
Yes.
able to move. But everything that we do, to do surgery or intervene, is trying to give a temporary fix. And that's not going to give you the long-term goal. Once those arteries are diseased, and we're doing bypasses or balloons or stents or whatever you have you. But again, once your pipes in your house are old, you're never going to get them pristine again. You may be able to rotor-root them, clean them, but you're never going to get it perfect.
And I think Marcia wants to jump in. Marcia, go ahead and jump in and talk to Dr. Kumar Madasari, our Humanitarian of the Year.
Hi, congratulations.
Thank you.
This is exciting. Well, I love your compassion. I mean, it's obvious why you're getting this award, but and I love that you were frank with that patient and really just said, you can have, it sounds like what you were saying is you can have as many surgeries as you want, but really you have to start helping yourself. But why don't doctors explain to patients that it's temporary? Like when I went in and had intervention, I thought I was fixed. 3 months later, I couldn't figure out what happened. I hurt
Yeah.
again.
That's a very loaded and tough question. I think because all of us, especially in medicine, we want to fix things. We want to feel like you're coming with a problem, we fixed you, and you should be very happy and not thankful, but we did something good for you. But if you do enough of this and you see what happens, you look at outcomes and you do enough, you learn good and bad. I think honesty matters more than anything else, because it's almost like selling you a false sense of goods, to make you
Right.
think that you just have this problem, we just have to fix it, and then everything's back to normal. There's almost no scenario in the blood flow system that once it's chronically bad, you're going to make it brand new again. You're not. And that's a reality. And
Yeah,
I'll tell
it
you, some
makes
some
sense.
patients don't also want to hear that either. That's the other part.
And Marcia,
Had I known that, I might not have had my intervention. Had I known that in 3 months, you're going to be right back where you are now, it might have really inspired me. Well, I was walking anyway, but it would have inspired me to just walk through that pain, just walk
Yeah.
through it. Cause that's what I'm doing now. Anyhow, it's all
yeah,
blocked
she
up.
did. Once she actually, and this was amazing. Marcia's
Wow.
like the perfect example of this. That once the doctor, the vascular surgeon, and I was there for this meeting, explained to you exactly, and I'd rather you say it, but I'll just lead it off. But he said, yeah, you're blocked. I could do a bypass, but look at what you've done since the last ultrasound. I mean, this is amazing, right?
Yeah, so I went from my cardiologist who had done a few interventions on me and I was blocked up again. And he was like, well, I'm just going to refer you to a vascular for a bypass. And that was a long wait. And when I walked in, he opened up the door and he literally said, you do not need a bypass because I had created collaterals, but
Yeah.
I did it the hard way. And had I known that I was going to do it the hard way anyhow, I wouldn't have had the intervention. I thought I
Yeah,
was getting fixed.
I don't know anything in our lifetimes that's the good things that are easy. That's just reality. I think anything that is going to be long term and good for us, we have to kind of earn it, which whatever it is in life. So
You're right.
I don't want to make it nefarious that people do procedures for ill-gotten means, but that does happen too. But if someone's truly complaining of something and the workup says there's problems, there should be a good conversation about, let's set some realistic expectations about this.
Yeah.
This is almost a band-aid. How long that band-aid stays on, we can't really tell you. I've seen interventions that we've done stay open for 5 years, but I've also seen them stay open
Oh.
for a week. I've seen bypasses stay open for 7, 8 years. I've seen the bypasses go down within 2 weeks. So is it easy to predict every patient? Yes. If you're a healthy young patient who's not obese, who has a long blockage and a good vein with a good surgeon and a good recovery and good health, your bypass may do really well. That is not the typical patient I see any single day of my life. And that's not the scenario for everybody. And does your blood like the blood thinners that you take? Does your environment allow you to walk every day? There's so many factors that
Yep.
the reality should be, if you're really struggling and you've tried everything possible and it's affected your quality of life, then have a realistic expectation and discussion, knowing
Well,
that
that's
not,
just it. A realistic expectation.
Yep.
Because I thought it was a fix
and
it wasn't. But anyway, thank you.
look,
The
I'm,
Martian's
I'm
doing
so
great.
happy to hear that you've fought through it yourself. And honestly, it takes self-resolve, and it's not easy, especially if you're in
Nope.
pain, if you don't have support, or if you're mentally having a tough time dealing with it. Mental health is a big concern right now in our society. It's always been, but it's ever more present right now. So I think that should be a strong focus in this disease state.
And I think that's the perfect transition to Douglas. Douglas, go ahead. You had a comment to share or a question for Dr. Kumar Madasari. Go ahead and unmute.
Yes, sir. I have a couple quick things. Number one, yeah, you're absolutely right. And I agree with her, if I had known what I know now, I would not have had both bypasses, period. I'd have gone to the second, third, or fourth option, that I would have found another doctor that would have been willing to go do something else. And I think today, for me, I'm speaking for me, is what you said about having the doctor listen to me is probably, I feel like when I walk out of the office is more important than what we decide to do or not do. Does that make sense?
Absolutely.
It really does, because I had to call a neighbor to help me move some stuff this morning because of my graft. And he asked me, he goes, well, they haven't fixed that yet. And it's like, can't find anybody to do anything. And we talked about it, and I just basically said, he asked me the same thing my brother does. If you found a doctor willing to go in and do whatever it took to take that out, would you be willing to take that chance? And it was like, I wouldn't even think twice about it. You want me to sign right there? Let me sign right there. I'll release you of anything and everything if you can go in and change my life today about living with this graft. It would, and that, I think that's having a doctor listen is probably, the mental health side of it is probably more important than driving home knowing that I was heard. I was actually heard. And for you, I have to admit, God puts people on this planet for specific reasons that he can't do, and you're one of those. So your purpose and your ability is a given talent, and when you go home tonight, think about that, is that you're his right hand doing what he can't do physically. I hope I didn't go too far with that, but I hope that makes sense to you.
That's incredibly kind words, sir.
Yeah, he even brought tears to my little crackle in my voice.
The one issue, and I'm glad you share that, is that the system in healthcare is a little tough. It's designed to make things quick, move on, and that's something I don't know how we can completely battle. We have to do a better job of that on our side. It's just the way the systems are designed now. It's ridiculous.
I would love to have that conversation with that doctor who put that graft in me. Did you even think about anything else other than just doing that graft? Was there any, did you go to any training? Have you tried anything else besides just doing that? And did you realize what that would cause in my life further down the road? Mine didn't last 6 months.
It was the axillary bifemoral
Ex
bypass.
bifem. Yeah, I remember hearing about it. Yeah.
It
Yeah.
didn't last at all. And now, even today, 3 years later, it still affects my life every day, all day long. So it's like, I was wondering, on their behalf, I would love to ask him that question. Did you think, or was it just that easy to do? And he's a good doctor, he's a nice guy, but did you think about anything else?
Yeah, I think we have to do a better job in our world to get people comfortable saying, "Hey, this is something that I can't do, but let me get you somewhere that can do something." And unfortunately, that's not part of our system. I don't. It may be a combination of ego, pride, patient ownership, financial, I don't know, but it's really tough for people to comfortably say, and I see it all the time, hey, this can't be done, but let me find someone who may be able to do something for you. Because it's often very not hard to find somebody. I mean, you have Kim, who's out there beating a drum to everybody, but as physicians, I'll tell you this, if a lot of those physicians had a family member with a problem, they would find somebody to help them. We have to remember that scenario of that every patient should be like your family. It's a tough thing when you're in the day to day and people forget that, but I think that helps you put that in perspective sometimes. I mean, especially if physicians. I mean, I've dealt with my mom with her cancer, and we took care of it. We dealt it. I think seeing that perspective sometimes changes your perspective of what someone's going through, and I think
Is that part of that ego? Last thing, I had gone back after it failed, and he looked at me and said, I had one job to get blood flow. That's what I did. See you later. And it was just that simple.
yeah, I think that seems like a little bit of a personality, characteristic that maybe wasn't the right person for you, unfortunately. And I'm so terribly sorry you went through that and you're dealing with it, because it's a lifelong thing you're dealing with. I mean, a lot of what we do, it's sometimes hard to see what the sequela downstream effects may be or could be. And I think, that's something I would always say, and Kim does a great job of this, telling everybody before you have anything done, get another opinion. I mean, I have so many patients who are scared to come to the city from Indiana because of the traffic and the big buildings. Yet, I guarantee if someone told them that they had breast cancer, they would buy a ticket tomorrow to go to Mayo.
Mhm.
So it's just getting people to understand to ask for the best option, another option.
Yeah.
Unless you're in a critical situation where you're in the hospital with life-threatening scenario, most of the time you have time to get those questions and seek those other opinions. It's just we don't do a good job of telling people, why don't I help you get us another opinion? Why don't we send you somewhere else? We just don't do well with that medicine, and I don't know. I'm not
And
sure
it's
how to do it.
also, I think there's a lot of responsibility, I think, for the patients. I can't tell you how many times in our social networks where people would lash out at me because I was very direct when they would post, hey, I'm having this other procedure. Anyone else have this procedure? And all they want to hear are affirmations and positive things about having that procedure, because of course they're scared out of their mind anyway. But you know what? Maybe I'm going to be that saving grace for you that prevents you of making a wrong decision. And yes, I get the fact that you're in pain and it's debilitating. And every day that you put off sometimes having a procedure, it's almost like when they finally say that the insurance is approved, they've done the pre-authorization, you have a date, it gives them hope again. And then when someone like me comes in and goes, whoa, 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 because I've been in these procedures, I've been doing this since 2016 around the world. And I'm like, not every procedure with every doctor is going to have the same outcome. And in fact, every procedure could lead you closer and closer to an amputation, some sooner rather than later. So we've got to say, stop for a second. Did you ask these critical questions? Do you have the ability to go antegrade, retrograde? What's your threshold before you give up? What's your contingency plan when that fails, which is what Marcia was talking about. What is that contingency plan? The contingency plan is when that fails is for you to have grown collateral vessels.
Yeah. I don't think it's hard to put all the pressure on all of you as patients. I mean, you go to a hospital, to a physician, or to a medical center with trust, and you're very vulnerable. So it's tough to say, you should have done this. And I hate saying that to people, but it's kind of like you go in there assuming that you're going to get good care. You're going to get whatever's the best care everywhere you go. That should be what the standard is. And
Yeah.
that's just not reality in any part of life. So the onus of your health has to be your number one priority, and you have to set the expectations at the highest level. And that's just the reality of life. And Kim does a great job of telling you all that.
I know. Sometimes my directness gets me into trouble, but my intention, I mean well. And I also think that I think that 99.9% of doctors, they mean well. Just sometimes the execution, which is what makes you really stand out. And I'm curious, how do you mentor the next generation? You have your own conference and you're mentoring the next generation of these doctors. How do you express what you do that helps you be deserving of this Humanitarian of the Year award? And I think that this is the first Humanitarian of the award given for someone who's treating peripheral artery disease, because it is so tough to treat. It's a really tough disease.
Yeah, I don't know how to do things for this award, but I'll tell you that, in medicine, mentorship is kind of what we're supposed to do, especially if you're an academic center like we are. I have 27 residents. Now they go
Wow.
through all the different things. They train with all my colleagues in the hospital. It's like 27 children, but just like a parent, I have two children. Our job is to make sure that they're equipped with what's needed to be great in life. And that's kind of what we have them for 6 years here. You have your children for life, but at least 18 years, you try to do the same thing. I think what you have to do is lead by example. Um, I think I see my residents and fellows can see me in clinic. They can see me in wound care. They can see me doing conferences, talks, and stuff like that. And I think the best thing to do is lead by example. I think children, everybody on this call was a child one time. You remember your parents. You remember what they did, how they did it, how they talked to somebody, how they interacted, how they talked to each other. So I think even in medicine to this day, that's important. And I tell them, hey, everybody you treat should be like your family. Everybody you work with, maybe your colleague one day, maybe your patient someday, and also you may be a patient one day on somebody else's table. So that karma has to play a role in your life. And I think teaching them how to reach out to other specialists. I try to espouse a very big talk to other specialists, reach out. I mean, they see me with my circle of friends who are vascular surgeons in this country, who are cardiologists, who are other specialists who typically are not told to work together that well, just because how systems are designed. And if they see that interaction, I hope that transgresses whatever they're otherwise taught. And the meeting that you were mentioning, that meeting's goal is to get all three specialists, but just trainees together for a weekend, completely hands-on with cadavers and every product in PVD. But the key is that it's all three specialty trainees, but I have all three specialty of my friends as faculty, the people that I go to meetings and we hang out with, we break bread with, they come to my house if they're in town for something else. Those of us are going to show them how we are friends in and outside of work, and how they should learn to be like that. Because then when that openness happens, they may be willing to ask for help, to send for another opinion, to reach out wherever they work in their future. So I think it all comes down to lead by example, give them the tools to, just like literally just like children, give them the tools to succeed so that patients get the best.
That's beautifully said. And I think Alan wanted to comment. You know Alan very,
Yeah, I
very
know
well.
Alan very well.
And he was actually one of the reasons, you got nominated. He was one of those. So it would be great if he had a moment to share his.
I had nothing to do with it. I thought Goldzar should have got it, but
Wow.
no, he's you know me. I've told you thank you so many times before. You made being in Rush Hospital is a big place, and each day I've had, even when you weren't taking care of me, you always came to check on me and make sure I was mentally okay during my long stay there. And I appreciate everything that you've done for me. Thank you.
Pleasure. I mean, you've been through a battle, but I mean, you've kind of fought through it yourself because you found the will.
I'm still fighting. We're getting there.
Yeah. That's kind of the goal. Everybody has. I mean, it's kind of a fight till the end for everybody. If you don't have that will, You sometimes in any disease state, you kind of your mind is over your body usually.
Yep.
Agreed.
Thank you,
That's all I've got besides the funny I had.
No, it's always a good joke out of you somewhere, and I appreciate great seeing you.
Okay, I have 3 more. These are some doozies, okay? I know you're ready
Oh,
for
boy.
these. So these are for 3 different series that we have, and we're asking every single doctor the same 3 questions. Number 1 is for a Journey to Diagnosis series sponsored by Biomedics. Share a case that had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient. Or you can share a story of a patient whom you just could not believe they had all these other procedures done, no symptom relief, like a spinal fusion, and all they needed was a PAD diagnosis and blood flow restored, and voila.
I wish
like
there
that
was just I wish there was one.
Oh,
You know,
no.
I had a patient, I think 2, 3 years ago, who came in with a wound on their foot, and long story short, talking to them, they had a 5-level lumbar spinal fusion, had about 15 venous procedures on their legs, separated by a couple months each. Had spinal stimulators placed, which goes into your spinal cord. Had hip replacements because there probably may have been some arthritis, and then come to this point. This patient has had probably about 27 procedures over the course of procedures over the course of about 5 years, and now they have a wound on their, their leg that was being told needs a major amputation. Now, major amputation, if everybody doesn't know, that means above your ankle. So that means either a below knee amputation or an above knee amputation. And turns out this whole time the patient had both iliac arteries occluded, and no one bothered to work that up when they were diagnosing their back pain, their hip pain. The venous stuff, there wasn't even terrible varicose veins or this and that. So this patient had 27 procedures when probably just fixing the iliacs would have prevented all of these surgeries. So fix the iliac arteries, which is a typical procedure that we can do, and the wound healed, and they did not get a BK or AKA. They got a wound healing. So that stuck out to me, for someone to go through the system, and we failed them. We all failed that patient. As a whole, in the medical community, we have to all take onus that we failed that patient, and that patient could have died on any one of those surgeries, could have had paralysis, could have had complications of hip replacements, this thing, that thing, all when a simple workup and test could have probably maintained them, prevented them. Maybe early management could have been enough to collateralize them to be fine in life. Instead, just progress with no management.
It's interesting. My dad just had one of his veins super glued, and he has a series of 3.
Yeah.
I call it super glued. He had the veins closed off. And leading up to this, and it's been about a year in the works, he's had heavy legs, and he's had a couple of venous ultrasounds, and they just kind of brushed him off and said, oh yeah, you're fine, whatever. And then he went and got so they said, go get your back checked. And of course, who doesn't have a million things going wrong with their back once they hit age 40? I mean, it just goes downhill from there. And so you have a lot of things going on with your back, but a lot of times that kind of masks other things, right, that are actually going on, or overshadows when it shouldn't. And so with my dad, they were talking about doing some major back surgery on him. And thank God for Dr. James Joy here in the San Francisco Bay Area, who said, whoa, hold on a second. I think it's just your veins. And he had one of his techs do the ultrasound, who specializes in that and does them all day long, every day. And he felt relief after the first one.
Oh.
He suddenly walked 1.5 miles for the first time in a year, after just the first one was closed.
That's
less
incredible.
swelling. He could put his shoe on. So I really think that the human superhighway literally should become a primary focus for people before any major procedure anyway. Check
Oh,
the
yeah,
veins,
sure.
check the arteries, right?
I think in a perfect world, we've gotten to the point where at least in America, there's screening for breast cancer at 40. You do annual mammograms, but we don't have anything for screening for PAD, which, in a perfect world, or maybe we'll get there one day, when you're at a certain age with risk factors, automatic screening. Because if you don't do screening mammograms, primary care physicians and everybody else get docked or dinged, and hospitals get dinged. Those are quality measures. We don't have such a thing for PAD, and that should be an initiative that we need to work on.
And there's one, the ARC Act, and it's just
Yeah.
stalled out in Congress, and it's just that
Exactly.
there's so many issues, and I just think that there shouldn't be any issues. I think that it should just be a given that it is a human right to get this test, especially when you have diabetes. Everyone at the age of 40, if you have diabetes, if you have pre-diabetes, if you have high cholesterol, high blood pressure, been diagnosed with heart disease, valvular issues, aneurysms, like you should be tested for PAD.
Totally.
Period. Yep. Okay, two more loaded ones. Okay, here we go. Share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in some sort of direction. It could have been 6 minutes you watched in a show, a documentary, a movie, a conversation that you had, something you witnessed. It could have been something that was eye-opening in any occasion. Dinner.
Interesting. For my life, I'd say I can probably sum up the events of this into of what I can picture in my head. 6 minutes was when I was a resident, to go into IR, you go through radiology, and then you do fellowship in interventional radiology, and then you do whatever. And as a resident, I had the fortune or unfortunate of diagnosing my mom stage 4 pancreatic cancer. I thought it'd be cool to show her, hey, I'll get you a CT in my hospital. It'd be cool. I'm the resident. It's great. Instead, turned into a 13-month nightmare. But I was like, oh, if you ever get sick, it'd be great for you to help your family. But the part of the story is you go through this process, you try to become the caretaker, the doctor, but also you're trying to be the son. You have a family, you're trying to support the family, and then when you can't get them to a curative scenario and then they pass, you feel like failure. So I sum up the 6 minutes into that experience, that exposure, that the ups and downs of that, the emotion of that, into how can I do better for everybody that comes into my room, my clinic, my table. So that 6 minutes was 13 months, but I can sum it up in my head in 6 minutes of a sequence of events that happened that made me change my focus and how I want to be a physician or what I want to do. Now, is that going to happen 100% of the time? No, but it always sits in the back of the head as just put that back in perspective, what it felt like to be part of that, to see the experience at home, at work, every day in the hospital, to do all these procedures on my mom. It's kind of like nothing hits close to home like that. And using that as a motivation would be my 6 minutes of my life.
And I almost feel her with us as this just exemplifies, exactly why you are the humanitarian of the year. I mean, you just are. You embody every aspect of it. So thank you for sharing that. And I have one more, another doozy. And this is for a series called The Pulse. I want you to share a case with a big lesson for you and others, you and or others even. Describe the patient, the frustration with the case, and the lesson you learned, and maybe others can learn from it. And it could be a success, it could be a failure, and maybe it might even include a little ingenuity as well.
So I had a patient about 3 years ago who came from another state, only about 40 years old, diabetic, and health-wise, obviously besides diabetes, was not overweight, didn't have any heart disease, but had a wound on his heel, from his diabetes. He has neuropathy, so he doesn't feel a lot of things, and he works. And he developed this wound on his heel that got worse and worse and worse. And at 40 years old, married with a kid, he was told you need a major amputation because his blood flow in his foot is terrible. And he's only 40 and he's walking, he has a life. And, three different places had said there's nothing but a major amputation. So, of course, being cocky is like, we can do something because he's coming desperate. Your patient comes vulnerable and you're young and you shouldn't have to face this at any age, but especially when you're young. So I said, you know what? I don't care what they said, we can do something. And, the deep vein arterialization is something that I offer and I do. And I said, we'll figure something out. Get on the table, and the angiograms I had seen from this other state were very not detailed, which is very important when you're doing these things. And I saw what we call an orphan heel, which means that there's blood flow everywhere in the foot except for the heel. There's nothing. And I go, I really wish I hadn't promised a lot. That's one. It's like great. So then, I said, okay, I'm gonna just go ahead and do a DVA anyway. And to do a DVA, you need good venous circulation in your foot. You need the anatomy to work. And I committed to us. I got this. I'm gonna do it. So I get everything ready, get in the vein, do all. I got everything prepped, and it turns out his veins are not normal. I'm like, okay, so strike two, overpromised. Shot myself in the foot, and it's humbling when you realize you have to learn how to set the expectations like we've talked about. So in that moment, I had already tried to create the DVA, then found out the venous anatomy is not normal in this patient. And so I had to come up with a way to get more blood flow. And although the DVA, which is supposed to bring blood down a vein instead of an artery because you have no arteries left, should go around your foot and the veins, it kind of just stopped at the ankle and escaped back up towards his heart, up his leg. So decided to, in interventional radiology, we do a lot of techniques with coils and this thing and that thing. So was able to take out a few vessels that I felt were stealing blood flow and redirected the blood flow towards the heel a little bit. And it was a shot in the dark. And the humbling experience happened in the room when I came out and I told him in the family, I said, listen, I don't know if this is going to work. I'm not confident on this. I'm not confident ever when you're in a DVA scenario, but we're at this point. I think there's a lot of spiritual help out there in the world, but somehow his DVA survived. He underwent several debridement skin grafts, and he was actually one of our a news story piece on Fox News. He's walking, and he has a foot, and it healed. But that's a good success story. But the points of that difficulty in that is saying how not to take on everything with confidence, how to set those expectations, how to reel back in your emotional experience with that patient. And it's very humbling, and it humbled the heck out of me, I'll tell you, even doing complex things like DVAs. Finding out that maybe I should have said this may not work, done more detail workup. I don't like to stage my patients, I don't like to do that, but sometimes maybe I have to do that again. So it was a very humbling experience altogether. But the fact that it ended up in a success to the point where his podiatrist in his other state was shocked. He was telling his other friends, we need to learn more about this stuff. We need to work together. And that becomes viral out in other communities where they can find physicians. We can help connect them. So you never know how it springs.
That was amazing. Because the amazing part of it is that this person was on deck for amputation anyway. So the worst thing that was going to happen is they were going to have the same amputation as before. But you're right in that, hey, we're going to do everything we can here, but you're already on deck for amputation. So a lot of what we do, it's going to be in the shot in the dark. Now, we're not going to put you in a worse position, right? That's the whole key. Don't put the patient in a worse position than they were before, where they're going to risk more than their leg. They're going to be risking their life.
Yeah.
And we've seen that before. But, if you're taking that cautious approach, right, and it's very measured, I think every patient understands and they appreciate it.
I think, I will say that as you learn more and more, and you do more and you work with more, we have to change our narrative. And, anything we do can have a complication, can have an unexpected
Yep.
outcome. there's anesthesia problems, there's there's stent problems, medication problems, blood bleeding problems. If you do enough of these cases as a physician, you're going to learn things on what can happen that you didn't expect, and that's reality of anything. Anytime you get touched with anything, something can happen. Also, amputation for some people is a completely acceptable answer,
Mhm.
but we need to have an open discussion about what that is. There are ways to have people have those discussions about what the recovery of that is, and educate them with prosthetics and things if they have to go that route. But we can't just say no one should have an amputation, because some
Nope.
patients may say, I'm not willing to do procedures and surgeries and debridements and this thing and that. That's that person's body. We have to respect that, but we should help educate them into what that means. And I think
Yep.
these are the learning lessons from saying one thing your whole life and then saying, wait, why don't you, do you want to hear about this? Do you want to know more about that? Have you understood what that means, what the recovery of all of this stuff is?
I love the way you ask the questions, and I think that it sparks the conversation. It steers you in the direction that you need to go to individualize that patient care, which is, again, one of the main reasons why you are so deserving of our very first Humanitarian of the Year award. Dr. Kumar Madazeri, we appreciate you so much. Thank you for your time. Thank you for your commitment, your compassion, and your dedication to saving life and limb, going above and beyond in saving life and limb, and helping to instill hope, faith, and so much courage, in these patients.
I incredibly humbled again. You and the patients are what motivates us and should motivate us, and we'll just know that a lot of us are trying to make it better a little bit at a time, and just hang in there. But reach out. Kim's an incredible mom. Thank you so much. This is a very humbling award, and something I'll cherish forever.
Thank you.